Hello everyone, my name is Cory Johnson. I'm one of the nurse anesthetists here at Pullman Regional Hospital. I'm here to talk to you tonight. I've been invited tonight to talk to you about pain control that we offer here at Pullman Regional Hospital for your labor experience. I want to start out by thanking you for being here. It's always really nice to see people engaged in their health care and wanting to know more about the decisions they may have to make at critical points during their stay here at Pullman Regional Hospital. We're going to go through several pieces of pain control. We'll go through the anatomy, we'll go through the procedure of placing it, and then we'll talk about some scenarios that may take place in your experience here at the hospital. So first off, let's just talk about the different types of pain control that are available for labor here at the hospital. One of the most important ones is the things that you're learning in this class today: your breathing, your focus techniques, your Lamaze lessons. All of those techniques are used for you to get through portions of your labor before you're at a spot where you can receive an epidural. It's very important that you take those lessons seriously, that you practice them with whoever your coach is, because they will become very, very important during your labor experience before you necessarily meet with me. The next phase in pain control for labor would be IV pain medications. Those can be ordered by your physician or by an anesthesia provider to provide pain relief with an IV narcotic to get you through a portion of your labor experience that may be more uncomfortable than another. These two techniques, both the Lamaze, the breathing, the focused, and the IV pain medications, are helpful in helping you attain your natural birth experience, if possible, kind of a bridge through some of those more difficult times in your labor. We move from IV pain medications, and here at Pullman Regional Hospital, we do now offer nitrous oxide as a potential anxiolytic during your labor experience. I don't have an example of that here, but what that entails is a mask that you hold to your nose and mouth, and as your contraction begins, you start breathing nitrous oxide gas. That's an anxiolytic. It's also some slight pain control, and you breathe that as you go through your contraction, and it does help. It can help with pain control during that experience. Going on from nitrous oxide, we get to epidurals, which is kind of my expertise, or our expertise, as far as anesthesia goes in labor pain control. Epidural is a procedure that's done by anesthesia in most instances. It's placed in your lower back. It's placed with a needle. A small catheter is placed into the epidural space and left there, where medication goes through that catheter to help with pain relief during your labor experience. And so we're going to talk about the process, the anatomy, and how it works, just because that's kind of the biggest piece that anesthesia provides when with labor pain. So let's start off with a little diagram of what the epidural space looks like. Okay, we're looking at the back of the patient and the front of the patient on this side. You're seeing two needles going into two different spaces in the spinal area. Okay, the top needle is an epidural needle going into the epidural space, and you notice it depositing medicine in between the green and the yellow line there, which is the epidural space. Okay, the bottom line, or the bottom needle, is a spinal needle going into the subarachnoid space, or the spinal space, depositing medicine there. Two different approaches at providing pain relief in the spinal area for labor, used at different times during your labor experience. We're going to go from our diagram to our skeleton model. Skeleton model has been used quite a bit, but this is a good representation to kind of talk to you about positioning for epidural placement. Okay, and if you look at the 5 vertebrae coming out from the pelvis up, you have 5 lumbar vertebrae. okay? In any of those 5 lumbar vertebrae, we can place an epidural catheter. The main thing I want to that I'd like to get rid of some rumors about right now is that you may have heard that an inadvertent placement of a needle during epidural placement can paralyze you. I hear that said quite a bit. That's actually an inaccurate comment that you might be hearing. The spinal cord actually ends as a cord itself at the L1 vertebrae, and so the spinal cord as a whole, going down through the lumbar region of the spinal column, is not a spinal cord at that point. It's individual nerves, and therefore, you being paralyzed from an inadvertent needle placement is just an inaccurate comment, and it doesn't happen. So let's dispel that right off the bat. The most important piece of placing an epidural is positioning. And you'll see that with this diagram as I show the flattening of the lumbar spine. And you may see it, I'm not sure if it's showing or not, but you may see that in between these spinous processes, the space gets larger as we flatten out that lumbar spine, okay? Normal curvature, something like this. Would like to see you position like this, opening up the spaces for us to have easier access for needle placement, okay? We'll be done with that diagram now. Let's talk about the procedure and positioning, okay? In order to get your lumbar spine into that position, we need you to sit up straight and then slouch your shoulders, tuck your chin to your chest. We kind of have you fold your arms in your lap with your palms up. And you're going to do somewhat of a pelvic tilt and flatten out your lower back, kind of like a Halloween cat or a shrimp. As you can if you can imagine those 2 actions. It's a pelvic tilt and kind of a curl over your baby. This flattens out that lumbar spine and allows us easier access with the epidural needle. Okay. During the process, myself or one of my partners will be instructing you on how to position yourself, as well as the nurses in the room. It's not something that you need to remember from this class, but familiarize yourself with it. The next phase of that procedure will be you sitting on the side of the bed in most instances. On occasion, we'll have you lay on your right or left side for placing the epidural. But in most instances, you're going to be sitting on the side of the bed as far back as you can get with your knees touching the edge. I'm going to be standing behind you. I'll clean off your lower back with some sterile soap. I'm going to apply a sterile drape. It's a sterile procedure, sterile gloves, mask, scrubs, hat. I'm going to identify the L3-4 interspace is where we like to start. I'll identify that, place my thumb in that region and kind of give you an idea of where we're going to start. And I'll let you know that there's going to be a small needle poke, okay? We use a small needle to numb up the skin and underlying tissues before we place the epidural needle. This is oftentimes described as a bee sting or a burning sensation. It's usually the most uncomfortable portion of epidural placement is the numbing portion. After that, you should feel nothing more than pressure and or a paresthesia, which I'll talk to you about as we go through the rest of the procedure. After the skin and underlying tissues are numb, we're going to place an epidural needle. I'm going to show you what an epidural needle looks like. It's a larger and longer than normal needle that you might anticipate. This needle is used so that we can thread a catheter through it. It's also got a specific shape to it to help protect from placing this inadvertently into the intrathecal space where we don't want to have this catheter placed. The needle is slowly advanced through the skin underlying tissues, through 3 layers of ligament, and approaching the epidural space. When we approach and we enter into the epidural space, you may feel an increased pressure sensation in your lower back as we instill some normal saline there. And at that point, we're going to thread an epidural catheter through that needle. During this process, the catheter is actually entering into the epidural space and passing by some of the nerves within that region. When that catheter is advanced in the epidural space, you can feel what we call a paresthesia. What that means is that you may feel like a funny bone sensation that goes into one side of your bottom or the other, or even down one leg. It's usually not both sides, it's usually one or the other. And we need you to let us know what you're feeling. Holding still is possible, but letting us know what you're feeling, because we redirect the needle and or the catheter away from those areas of paresthesia. Those experiences of paresthesia are not dangerous. They're dangerous if they are persistent and they don't go away. When I say dangerous, they're not necessarily dangerous. It just means that it may take longer for the nerve to recover from that stimulation, not likely permanent damage. Once the catheter is threaded in place, we remove the needle. The catheter is secured in that space. We do what's called a test dose. We use some local anesthetic with some epinephrine, which is a medicine that when entered into the bloodstream can make your heart go a little faster. We utilize this test dose to determine whether the epidural catheter was inadvertently placed in a blood vessel or near a blood vessel and or in the intrathecal space. It gives us two references when we utilize that. Once we've done that, we may ask you a couple questions about, do you hear ringing in your ears? Do you have numbness around your lips? Do you have a strange metal taste in your mouth? And are your legs or your feet numb and tingly? All of those answers help us determine whether the test dose was positive or negative, okay? Once we've determined that the test dose went well, we don't have anything to be concerned about, we finish securing the catheter to your back, and we would go ahead and initiate our initial bolus or volume of local anesthetic into that catheter, into the epidural space that starts the process of pain relief. The pain relief is not immediate with an epidural placement. It takes anywhere from 10 to 15 minutes for the epidural to what we call set up, or for it to take its action. Over that 10 to 15 minutes, the intensity of your contractions should be reducing over that time frame. So you are getting relief, it's just not going to be instantaneous relief. After the 10 or 15 minute time period, we're going to evaluate and make sure that the epidural is working well. We have an epidural pump to hook up to the catheter, so you'll be receiving local anesthetic continuously through the epidural catheter. It'll also be set up in most instances with a button for you to push for phases in your labor experience later on. You may need some more medicine, and we program that so you can give yourself some extra medicine. At that point, we're going to lay you back on the bed, anywhere from about 25 to 45 degree angle. We don't want you lying flat for very long, and we don't want you sitting up for very long. The medicine that we place, the local anesthetic we place in the epidural space, kind of moves in the epidural space like honey. So gravity pulls on it. When you're sitting bolt upright, the medicine will slowly work down, and your numbness level will go from maybe above your baby and slowly move down. Same thing with lying flat. As you lie flat, the medicine will slowly move up, and it could get to a level that's too high. Again, it moves very slowly. The nurses monitor this really closely, and not a large concern for you, but just a reference point to talk about. Also, the nurses will be tipping you on your side. You've probably learned in your birthing classes that your baby can compress the large vessels against your spine and cause a reduction of blood return to your heart. And so we put a little pillow under your hip and tip you to the side. When you're on your side, the side that's down, gravity will be pulling the medicine to that side. That side may get more numb, and the side that's up becomes less numb. The nurses are very versed in understanding this, and they will help you move from side to side as needed to make sure that we maintain an even level of the epidural. So we've gone through the process of placing an epidural. I want to talk to you about a couple things regarding the epidurals. Epidurals are not 100% effective. We don't get to place them in the epidural space right where we want to. The needle goes into the epidural space, and we thread the catheter there in hopes that it goes, in most instances, right where we want it to go. Sometimes we can inadvertently place that catheter outside of the epidural space, thinking that we're in the epidural space. And in an instance like that, the medicine can't get to the nerves, and it may not be effective. In an instance like this, we simply have to remove the catheter and start over and place another epidural catheter, okay? Because of the anatomy of the epidural space, there's fatty deposits, there's connective tissue in that epidural space, and sometimes it doesn't allow the medicine to travel circumferentially around the spine at the spinal cord in the epidural space. And so you can have an experience where your epidural only works on one side. All right? We have some maneuvers we try in order to get this to work on both sides. We turn you to the side that's not numb to get gravity to pull it to that side. We may manipulate the catheter a little bit. But again, if we're not getting anywhere by manipulating the catheter and positioning you, we'd simply remove the catheter and start over and place the catheter at a different level. The third thing that can sometimes happen is that a patient will have a hot spot. And so you'll be numb everywhere but one spot somewhere on your tummy, in your pelvis. And every time you have a contraction, you feel the contraction in that one spot, but it's numb everywhere else. Very bizarre, I'm sure to feel. I've not ever felt that. But again, we do the positioning, repositioning the catheter, and if all else fails, we remove the catheter and replace it so that you have good pain control. Let's talk about the risks of placing an epidural. The risks of placing an epidural include infection. Simply because we're placing a needle through your skin, your protective barrier of your skin puts you at risk for an infection. With the sterile technique, we use sterile measures to reduce that risk. There's a risk of nerve injury. We're passing the needle by nerves. If there is nerve injury, it's most of the time it is self-limiting. It may be there for a few days, it may be there for a week, it may be there for 2 weeks. If it extends past 6 weeks, your obstetrician and anesthesia will consult on possibly sending you for further evaluation with neurology to see if we can find out exactly what's going on. But in most instances, if there's any kind of nerve injury, it's inflammation of that nerve or irritation because we passed a needle or a catheter by it, and it just simply needs some time to resolve. Bleeding is another risk. Not bleeding that comes out through your skin that you can see that you might want to put a Band-Aid on, but bleeding in near the nerves or in near the spine. That's why we look really closely at the medications that you're taking and some of your lab values to make sure that you're able to clot well before we place an epidural catheter. But even though we do that, there is a small risk of bleeding and bleeding in towards inside near those nerves that can cause pressure on those nerves that would need to be repaired. And what I mean by repaired is that we need to relieve the pressure because pressure on nerves can cause permanent damage. The last risk that we talk about is post-dural puncture headache or spinal headache. Okay, I'm going to reference back to this diagram really quickly. The yellow line that you see here that the spinal needle is going through is the dura, or the material that contains the cerebrospinal fluid around your spinal cord. Okay, that dura, if punctured by an epidural needle, there's a risk of cerebrospinal fluid leaking out of that intrathecal space at a rate that's faster than your body can recreate that fluid, and in doing so creates what's called a postural headache or a post-dural puncture headache. It's a headache that comes on when you sit or you stand, and as you lay back down over a few minutes, the headache goes away. Postural means that when you change your posture, the headache changes. Again, all these risks are all very, very small, but they are risks of the procedure. The post-dural puncture headache, we have treatments for. So if you experience those symptoms at home, we'd want you to call your obstetrician, call the OB department, or call the anesthesia department, or go to the emergency department if none of those are available to describe your symptoms to see if there's something that anesthesia can do to relieve those headache symptoms. The headache can be kind of debilitating and it can make it difficult for you to care for your baby at home. And it's easily fixed with some non-invasive techniques to the point of doing what's called an epidural blood patch if necessary. In a lot of instances, that's not necessary at all. There's a side effect, a common side effect of placing an epidural, which is low blood pressure. We're taking away your pain, we're taking away your sympathetic response, and the blood vessels below the area that's numbed, so to speak, dilate, and so you can have low blood pressure. To try and counteract those effects, we give you fluid before and during the procedure, and anesthesia has medications available to give you IV to rapidly bring your blood pressure back. That is placement of an epidural and the risks involved in it. The medications that we use in an epidural are local anesthetics, as well as occasionally we'll use a narcotic pain medicine in the epidural space. The nice thing about the local anesthetics in the epidural space is that we are able to use a low concentration of medicine with a little larger volume. That medicine goes in the epidural space and it doesn't come out of the epidural space all that easily because of the makeup of the anatomy in that area and the makeup, the chemical structure and charge of the medicine in that area. And so very small amounts of it come out of the epidural space and go systemically. They also go through a metabolism before they go to your baby. And so your baby may experience having a small amount of local anesthetic. It has little to no effect on your baby whatsoever. Oftentimes this is a question and concern that moms have is medicines getting to their baby. And in this process with this concentration of medicine, there's very, very little medicine that actually becomes systemic within your body that circulates to your baby. And so it's a very, very, very minimal amount and a small concern. The narcotic that we might place in the epidural space is usually just done with the initial insertion. It's just to help with getting you comfortable more quickly. That's done in communication with your obstetrician as well as the nurse. We discuss history of your prior labors, if you have a prior labor, or where you are in your labor process, to make sure that there's plenty of time for that medicine to be metabolized and be totally out of your system and the baby system before delivery. Okay, I think at this point we're done with epidurals, and I'd like to talk a little bit about intrathecals. Intrathecal is it's a spinal. We kind of distinguish an intrathecal from a spinal basically because we do an intrathecal for labor. We do a spinal more for surgery. And so an intrathecal is a spinal, although it's just a different dose of medication to help with pain control and not as much what we call motor blockade or making your muscles weak as well. An intrathecal is utilized for patients that may come to the hospital in an advanced stage of labor. And so say you are at home and you're using your Lamaze techniques and you're using your focusing techniques and your breathing, and you show up at the hospital and the first nurse checks you and you're 8 centimeters dilated or 9 centimeters dilated. And it's going to be a very short period of time before you're going to be at a point of maybe pushing. We might place an intrathecal first to give you quick pain control because of because the practitioners feel that your labor and or delivery may happen quickly. An intrathecal only lasts for a couple hours, whereas an epidural is continuous. We can make it last as long as we continue to put medicine in there. The intrathecal is needle in, medicine deposited, needle out, okay? So the process of placing an intrathecal is very similar to an epidural. It's placed in the same places as far as in the levels of your back. It only goes through that one extra layer, the dura. It usually is a fairly quick procedure, and the medication works really quickly and you get comfortable really quickly. I want to remind you again that the intrathecal is typically not something that a new mother gets or needs because their labor is oftentimes longer than a mother who's had a labor experience with one or more children. The risks are also the same. The risks of infection, bleeding, nerve injury, and spinal headache, and side effect of low blood pressure. Again, I'm covering this really quickly because it's not something that's often utilized for patients that are attending this class, but I want to cover it anyway. The next step of this class, I like to talk about some scenarios or things you might experience during your labor process here at Pullman Regional Hospital. And so I'm going to give you some scenarios of labor and delivery that could occur. And so we'll start with the first one, which is the ideal situation. You start your labor at home. You identify that. You may call the labor department and they encourage you to come in, or you come in on your own. And you come in, the nurses and the staff admit you to your room. They place the monitors on. They maybe do a cervical check. And you're monitored through your labor. You dilate to 10. Your obstetrician or whoever your provider is comes in, and you go through the pushing phase of your labor and you deliver your child. And everything goes perfectly. That's exactly how we'd love it to be. In that time frame, you may or may not decide to have anesthesia intervene for pain control for your labor experience. Totally up to you. We encourage you to do your best at whatever type of birthing plan that you have. The next step in a scenario would be that you come in and you're in labor and you get admitted and you're monitored and you're going through labor, and maybe some alarms go off in your room and your nurse comes in, and then your nurse may apply some oxygen to your nose and mouth. They may tip you onto your side or reposition you because the baby's showing some signs that their heart rate has changed, either gone up or gone down. Every time something like that happens, the nurses will tell you more than I don't really know as much, but they usually notify the doctor. The doctor oftentimes has access to review your fetal heart tone strips from home or from wherever they are. And so they're made aware. This may happen several times in your labor experience, and nothing changes. The nurses with their positioning and all of their skill get the baby to settle down, and you deliver naturally, and that's wonderful. The next step is that those alarms get persistent and the baby's showing more signs of distress. The heart rate is dipping down with contractions. The alarms are going off. The nurses have the oxygen on. They have you tipped on your side. They may even have you on your hands and knees just to reposition the baby, to try and maneuver the baby maybe off of the umbilical cord, or just reposition to decrease the stress on the baby. Those techniques may work for a while, and at some point, your labor physician may come in and meet with you and talk to you about the distress that they're seeing in your baby. They may talk to you about other options and whether or not continuing with labor is a good choice or not. At some point, they may say that a C-section is something that needs to take place. Okay, it still oftentimes is your decision based on the physician talking to you about your options. But if that was the case, we here at the hospital would make sure that there's a room available in the operating room. We go through getting you ready for that C-section as long as your baby's stable. Antibiotics would be placed, preoperative medicines would be given. Once the operating room is open and available and ready, we would go ahead and start placing a higher volume, a higher concentration of local anesthetic into your epidural, if you have one, which gives you a surgical level about at the chest level down, becomes numb. We take you to the operating room, we assist you onto the operating room bed, put on our monitors, and proceed forward with a C-section. The next scenario would be a scenario where these alarms go off and the nurses come rushing down and they put oxygen on and they turn you, and the baby's heart rate's not coming back the way they'd like to see it. And we move into what's called maybe an urgent C-section, where the doctor, if they're in the hospital, is here, will talk to you about a C-section, about the need to go sooner rather than later because of the distress your baby's in. Or they're on their way to the hospital to talk to you about that. In this kind of a scenario, you'll see things moving more quickly. Anesthesia will come more quickly. There'll be more nurses in your room getting you prepared. The operating room will be, it'll be more, how do I say more available, but there's just more urgency in it, just like it's called an urgent C-section. In that instance, you'll be prepared more quickly. We'll move you more quickly to the operating room. Again, if you have an epidural, we'll dose the epidural or place a higher concentration, higher volume local anesthetic into that epidural space that gives you that surgical numbness for the procedure. I need to back up just a second. I didn't talk about what happens if you didn't have an epidural. If you didn't have an epidural and we needed to go to C-section, we would typically do a spinal, okay? And again, we talked about both the spinal and the epidural placement. They're very similar. The placements are very similar. The difference is just how quickly it works for pain control and how numb and how dense that block is. So if you didn't have an epidural and you needed to go to C-section, or if your epidural wasn't functioning well, we would simply go to the operating room and place a spinal, which would give you surgical pain control for the C-section. Okay. The last scenario I want to talk about is an emergency C-section. Okay, and this is the scenario that we don't like to see happen. It happens very, very infrequently. I've been here for a little over 6 years, and I've experienced one. And so I don't know if that gives you any reference, but it's very infrequent that we end up needing to do an emergency C-section. But emergency C-section is something like this. The alarms go off in your room. The nurses come in, they position you, they put oxygen on you. They may or may not do that. They may simply come in, and a bunch of nurses may come in, unlock your bed, disconnect you from the monitors, and they may be taking you to the operating room as quickly as possible. The operating room staff is versed in doing emergency C-section if necessary. They're able to quickly open up instruments and be available to do the C-section. The anesthetic for an emergency C-section is a general anesthetic. You will go to the operating room, we'll position you on the bed. As soon as the surgeon is ready, you'll be given medicine into your IV, and you will go off to sleep, and we will place a breathing tube to secure your airway, and your baby will be delivered within a minute to 2 minutes. It's very, very rapid. This is a scenario where we want to get your baby out as quickly as possible to make them as safe as possible. So I want to talk a little bit about when you can get an epidural. I failed to mention that back when we were talking about epidurals. An epidural is usually ordered by your physician, and that's ordered by your physician usually when they determine that you're in active labor, okay? And what that means is that there's a bunch of different criteria. The nurses probably know the criteria better than I do, but some of it has to do with dilation of your cervix, the intensity or the strength of your contractions, your gestational age. All of those are taken into consideration to determine whether or not you are in active labor. When it's determined that you're in active labor, you can pretty much get an epidural as long as your physician has ordered it at any time. There is some misconceptions about epidurals slowing labor so that your labor will be longer. The literature states that epidurals do not delay the first stage of labor, which is 0 to 10 dilation of the cervix. There is some literature that states that there is some potential slowing of phase 2 of labor, which is the pushing phase of labor, which makes a little bit of sense because we've given you some medicine in your epidural space that decreases your pain response and also can decrease your muscle strength, okay? Along with the fact that you've been going through labor. So tired, weak, unable, or more difficult to push, okay? And so it doesn't slow your labor from 0 to 10, but it can slow 10 to delivery. It also does not increase your risk of C-section. Epidurals have not been determined to increase risk of or increase the percentage of people getting a C-section. And so just to make that kind of clear as best I can, once it's been determined by your physician and the nurses that you're in active labor, and the physician orders that you're able to have an epidural, you can have an epidural at any time at that point. There's an anesthesia provider on call 24 hours a day available to place an epidural. During daytime hours, there are times during the day when all the anesthesia providers are doing surgical cases, and there could be a delay in the placement of your epidural. This happens very infrequently. There's also a small chance that you may not be able to get an epidural. Again, very rare. This happens once or twice a year at most. Oftentimes, this happens when people come in and they're advanced in their labor to the point of pushing, and an epidural is not indicated at that time. I want to summarize. We went through epidural placement. We went through anatomy of epidurals. We went through positioning of epidurals, and we went through the risks and side effects of epidurals. We talked briefly about intrathecals and when they're utilized and what they're utilized for. We talked about the anatomy and the procedure for placing those as well. We then reviewed some scenarios of possible scenarios that you might experience here during your labor experience. I want to thank you again for coming to this class. The anesthesia department here at Pullman Regional Hospital is very glad that we're able to come and be part of this educational section and provide you with information for you to better make choices in your labor experience. We'd ask that any questions you might have, that you would pose those to your instructor. Those questions, if we're not available to answer them at the time, will be emailed to us, and we will get those questions answered and back to you electronically if we're not there in person to answer them for you. We look forward to seeing you during your labor experience, and hope we can make an impact in your labor experience.